Today's topic is status epilepticus. Let's see the definitions first. Early status epilepticus refers to seizures lasting longer than 5 minutes. Established status epilepticus, seizure persisting longer than 5 minutes despite treatment with benzodiazepine. Refractory status epilepticus, prolonged seizure that has not responded to 2 doses of different anti-seizure medications, meaning the patient received benzo and second line anticonvulsant. Super-refractory status epilepticus, seizure lasting more than 24 hours. Convulsive status epilepticus is the most common and most life-threatening. Focal status epilepticus can be without impaired awareness, otherwise called focal motor seizure, previously simple partial status, or with impaired awareness, complex partial status. Focal status and absent status defined as the seizure lasting longer than 10 minutes in those particular categories. Complex febrile seizures usually last longer than 15 minutes, occur multiple times in 24 hours. It can have focal features. Neonatal seizures we are not discussing in this session because it has different etiologies and has unique pathophysiologic mechanisms. Non-convulsive status epilepticus can have multiple presentations. It can be focal motor seizures or non-motor seizures or absent seizures. How does the status epilepticus happen? Failure of inhibitory pathways mediated by GABA and hyperactivity in excitatory pathways mediated by glutamate. It leads to neuronal damage, cell death, and alterations in brain networks. Seizures lasting longer than 30 minutes represents the beginning of neuronal damage with self-perpetuating dysregulation. Prolonged seizures leads to internalization of GABA unit A receptors, reducing the synaptic inhibition as well as the responsiveness of benzodiazepines. Status epilepticus leads to increased epinephrine and norepinephrine levels, promoting peripheral vasoconstriction to enhanced continued perfusion and oxygenation of the muscles and brain. It causes cyanosis and decreased oxygen saturation. The longer the seizure continues, it increases the risk of compensatory failure resulting in decreased perfusion, oxygenation, and glycemia. High rate of decompensation with the cardiovascular collapse happens if the seizure lasts for 20 to 40 minutes. Differential diagnosis for status epilepticus. It could be convulsive status epilepticus or non-epileptic events like psychogenic non-epileptic seizure. They will have a fluctuating course, retain awareness despite bilateral convulsive activity, asynchronous movements, forced eye closure, lack of labored breathing postictally, and rapid return to baseline function. The EEG should distinguish epilepsy from non-epileptic events. This particular slide shows what are the features favor psychogenic seizures or non-epileptiform seizures. Typically, it lasts long, more than 5 minutes. Number 2, it can have fluctuating course, waxing and waning. These patients will have asynchronous rhythmic movements, often have pelvic thrusting, side-to-side head and body movements during a convulsion. They often have closed eyes. They have ictal crying, and more importantly, they can recall of items during the event. These are all favor psychogenic non-epileptic event. At the same time, things like tongue biting, incontinence, gradual onset, non-stereotyped, flailing and thrashing movements, opisthotonus, associated injuries does not point towards the psychogenic non-epileptiform events. Status dystonicus is a rare, potentially life-threatening condition that can be mistaken for status epilepticus. The non-convulsive status epilepticus, it can have multiple forms. One, they can present like altered mental status like hallucinations, confusion, and coma. But they can have motor phenomena like automatisms, ataxia, dysarthria, sometimes autonomic changes like pallor and vomiting. These patients may have history of epilepsy or previous convulsive status epilepticus. Non-convulsive status epilepticus is associated with neuronal injury and increased morbidity even without clinical seizures. Very important point. And these patients need urgent intervention with the same medications. Since the presentation is very vary, it is important to have EEG monitoring and EEG done right away, and need to have continuous EEG monitoring till the seizure resolve. What is the incidence of status epilepticus? The incidence of status epilepticus between 1 to 19 years, about 10 to 58 patients per 100,000 population per year. The highest incidence of refractory status epilepticus occurs in children younger than 1 year. The male to female ratio favors, well, it's more so in male than female. The ratio is 1.2 to 1 to 2.1. There are no consistent differences by race or socioeconomic status have been reported in pediatric status epilepticus. So when you go into the etiology of status epilepticus, I'd like to separate into 6 different categories. 1, acute symptomatic. Number 2, remote symptomatic. Third, remote symptomatic with acute precipitant. Fourth, progressive encephalopathy. Fifth, febrile status epilepticus. And sixth, cryptogenic or idiopathic. Let's see what are the causes of acute symptomatic status epilepticus. Those are meningitis, encephalitis, electrolyte disturbances, sepsis, hypoxia, or intoxication. These etiologies account for 26% of status epilepticus. Remote symptomatic in previously CNS injury patients, it accounts for 33%. Remote symptomatic with acute precipitant. Previous CNS injury with concurrent exacerbating factors such as illness or hypoglycemia, it accounts for 1%. Progressive encephalopathy in children with underlying progressive neurologic disorder, it accounts for 3%. Febrile status epilepticus, it accounts for 35% of cases. And idiopathic unknown etiology accounts for 15% of the cases. Electroclinical syndromes such as Lennox-Gastaut syndrome, 10% of these children with epilepsy will present with status epilepticus as their first seizure. So when you have the first episode of status epilepticus, you have to keep in mind it is a Lennox-Gastaut syndrome. 25% of children with epilepsy develop status epilepticus in their lifetime, meaning all seizure patients need to be warned about possibility of status epilepticus and also how to prevent to becoming status epilepticus from the seizure episode. Preventing status epilepticus. As a rule, seizure is easiest to stop soon after it begins than after it has become persistent. And halting the seizure earlier should mitigate the adverse physiologic effects of a prolonged seizure. It's important to abort seizure before it becomes status. The medications available are mostly they are used in home settings, but it can be used in pre-hospital and hospital settings too. The medications available are intranasal diazepam, rectal diazepam, intranasal midazolam, oral dissolving tablets of clonazepam, and buccal midazolam. This slide shows the doses of different medication. The rectal gel diazepam, or otherwise called Diastat, 0.5 milligram per kilo for ages 2 to 5 years, 0.3 for 6 to 11 years, zero point 0.2 for patients more than 12 years age. Maximum dose is 20 milligram. Nasal spray is also approved for control of seizures. It's available in the name of Valtoco, 0.3 milligram per kilogram for ages 6 to 11, 0.2 milligram per kilo for ages more than 12. Maximum dose 20 milligram. Midas buccal administration with atomizing device, dose is 0.3 to 0.5 milligram per kilo. The max is 10 milligram. It is off-label use. Midas nasal spray, it's available as Nasilam. Initial dose is 5 milligram. Second dose given 5 milligram after 10 minutes if the patient has not responded to the initial dose, with a maximum of 10 milligram. Clonazepam oral dissolving tablets. The dose is 0.01 to 0.02 milligram per kilogram. It's again off-label use. Issues with rescue medicines. One, you need to teach the caregivers how to give the medicine both rectal and intranasal. And also what to watch for. The most common side effect is sedation. If the patient is already on opioid, barbiturates, including phenobarbital, respiratory depression is likely. In older pediatric patients, you have to account for alcohol use or abuse when they use the rescue medications. This slide talks about pre-hospital status epilepticus using intramuscular versus intravenous therapy. This particular study, they compared intramuscular midas versus intravenous lorazepam. They found 73.4% of the patients who received intramuscular midas did not have any seizures when they reached the emergency department. On the contrary, IV lorazepam, 63.4% abort the seizures when they reach ED. It shows the superiority of intramuscular midas. Number one, you do not need IV, and that controls seizures much better than intravenous lorazepam in the pre-hospital setting. Once the status epilepticus is already present, so you have to make sure the patient has an adequate airway, the patient breathes better, and circulation is good, and oral secretions, vomit is suctioned out, and medications for the prolonged seizures needs to be given, and monitor the vital signs, saturation and BP and heart rate. Early IV access is very important, and also the lab evaluation, especially glucose, need to be done right away, along with BMP, calcium, complete blood count, and anti-seizure medication levels if appropriate. Treatable causes of seizures need to be identified and treated immediately, like hypoglycemia, hyponatremia, and hypocalcemia. Then you should look for in an appropriate patients urine toxicology screen, metabolic studies, EEG, neuroimaging, and antimicrobials should not wait the test results if there is a high index of suspicion for CNS infection. The antibiotic needs to be given pending lumbar puncture. Instance of leukocytosis could suggest an underlying infectious etiology, and also subtherapeutic levels of anti-seizure medications could be the cause of status epilepticus in a previously known seizure patient. And urine and serum toxicology needs to be done in suspicious patients where the possibility of ingestion or toxic exposure is a possibility. As we discussed before, complete blood count, look for leukocytosis that could indicate infection. Serum electrolytes, especially hyponatremia and hypercalcemia, hypoglycemia, those are very treatable causes, needs to be identified and treated immediately. Anti-seizure medication level, especially in established patient. Serum and urine toxicology, if you suspect ingestion or toxic exposure. Lumbar punctures to rule out CNS infection and autoimmune encephalitis. Neuroimaging to make sure there is no structural etiology like abscess, stroke, hematoma, or cortical dysplasia. EEG to identify the seizures, and also ongoing clinical seizures control. So electroencephalogram needs to be done right away and also to be continued till the seizure resolves. These are the three. Timing is very important in the treatment of anti-seizure medications. One, the first 5 minutes. Number two is 5 to 20 minutes and more than 20 minutes. The first 5 minutes, stabilize the patient like monitor vitals, open airway, suction, supplemental oxygen, establish vascular access, assess the etiologies, obtain fingerstick glucose and other lab electrolytes, ASM levels is indicated. Administer first dose of benzodiazepine. Then reevaluate, prepare for intubation, administer second dose of benzodiazepine, and prepare for IV anti-seizure medications, that is second line medications. Get ready for it. If the seizure persists after second dose benzo, go ahead and give anti-seizure medications. If the seizure lasts more than 20 minutes, monitor airway, breathing, circulation, and administer dose of different anti-seizure medications. Prepare for continuous IV infusions. Consult peds neurology and obtain EEG. We will discuss in detail each and every step. This particular slide is done for adult status epilepticus, but it gives a little bit more valuable information. As we discussed earlier, the initial medications to control seizure is lorazepam IV 0.1 milligram to the max of 4 milligram. That can be repeated one time to the max of 8 milligram. That means it can be given only 2 times. If the patient doesn't respond, or even if the patient does respond because the effect of IV lorazepam or any kind of benzodiazepine is limited, so second line medication is a must. It could be IV Keppra, IV phosphonate and IV valproic acid, or IV lacosamide, or IV phenobarbital. If the patient is still seizing but responsive, then repeat the dose of the second line anti-seizure medications like Keppra, phosphonate, valproic acid, lacosamide, or phenobarb. If the patient is unresponsive, move on to give IV medications like midas, propofol, or ketamine. If he is still seizing, the patient needs to be on pentobarb coma. Additional considerations. Keppra is the first choice of second-line medications we use in the United States. Because it's immediately available, it can be used easily in liver disease and in pregnancy, and also better safety profile than other medications. Second, valproic acid, if there is a renal disease and myoclonic status or absent status, VPA, valproic acid is the first choice. Fosphenytoin is preferred over phenytoin because of higher incidence of side effects with phenytoin infusion, and also it needs to be given over 20 minutes. Preferred to avoid valproate with fosphenytoin. The common acute adverse effects with these medications are fosphenytoin can cause hypotension, cardiac arrhythmias, and somnolence. Valproate can cause hyperammonemia, hepatotoxicity, thrombocytopenia, and it is teratogenic. Lacosamide can cause AV block, bradycardia, and hypotension. When you're choosing antibiotics, if you're suspecting infection, vancomycin 25 mg per kilogram to the max of 2.5 gram, ceftriaxone 2 gram per kilo, in children 100 mg per kilo, acyclovir 10 mg per kilo, and if the patient is immunocompromised or more than 50 years, add ampicillin. In penicillin allergic patients, Bactrim. Pyridoxine and thiamine can be used in inappropriate patients. Another diagnostic pointers are if the patient get a CT scan if you suspect stroke, that needs to be done real quickly. And also when you do a spinal tap, make sure you have enough amount of CSF to send for cells, protein, glucose, bacterial culture, fungal culture, and also PCR for herpes, varicella zoster, Epstein-Barr, and CMV, and other autoimmune panel. The speed really matters. We all know age of the patient and etiology are the biggest determinants of outcome in status epilepticus. It also known at this point, achieving seizure control within the first 1 to 2 hours of onset is a significant determinant of outcome. Sooner we control the seizure, better the outcome. The initial medication for prolonged seizures are midas, diazepam, or lorazepam. Lorazepam is most commonly used to control the seizure. In the pre-hospital setting, IM midazolam in the absence of IV availability is probably the better choice. All these three drugs can be given IV. Midas and diazepam have intranasal formulations. Diazepam has rectal formulation. One thing, midas can be given intramuscularly. All these medications can be given intraosseously. So you do not wait for IV placement if it is difficult, especially in small students, difficult to get an IV access, and go ahead and give midas is the right way to do to control the seizure. The doses of these medications: lorazepam 0.1 milligram per kilo, max of 4 milligram. It can be repeated if the seizure lasts after the first dose of medication, so maximum of 8 milligram per episode. It's a rapid onset of action, longer duration of action compared to diazepam. Diazepam is, I have not used for the past 20 years, but still for less resourced countries, they can still use 0.15 to 2 milligram per kilo. Maximum cumulative dose is 20 milligram, 10 milligram at one time. It has a rapid onset of action, and the risk of drug accumulation, repeated doses, is the issue with the diazepam. Clonazepam, the dose is 0.015 milligram, maximum is 1 milligram, maximum cumulative dose is 2 milligram. Rapid onset, little drug accumulation, longer duration than diazepam. There is no trial data available for the usage of clonazepam. So at this point, lorazepam is the go-to, and if you do not have an IV access, IM midas is the best alternative. IM midazolam is easier, 5 milligram for children, especially children less than 40 kilos. If the weight is more than 40 kilos, 40 milligram. The maximum cumulative adult dose is 20 milligram, can be given 2 times too. It has a rapid onset of action. IMO has superior efficacy to IV lorazepam and IV or PR diazepam. Little risk of accumulation, shorter duration of action. Diazepam can be given rectally, and the lorazepam can be given intranasally too. When to give the second dose of medications? First dose needs to be given within 5 minutes. If the seizure fails to stop within 5 minutes after the first benzo has been administered, second dose of the same medications may be given. Because of the short duration of action of benzos, second line of medication is often administered even if the initial drug successfully halted the seizure. It's a very important point because even the seizure is stopped, go ahead and give the second line medications such as, we'll kind of discuss that. The second line medications are levetiracetam, otherwise called Keppra, fosphenytoin, and valproic acid. If levetiracetam fails to halt the seizure, fosphenytoin and then valproic acid can be added. Phenobarbital is a reasonable alternative if Keppra, fosphenytoin, and valproic acid are unavailable or ineffective. Phenobarbital, it fell out of favor even though it is very effective because the long-term side effects, it is not desirable, and in acute setting, in presence of benzos, it can potentiate respiratory depression and hypotension. So it's used, but used as a last resort. Lacosamide can be given IV, generally well tolerated. There are data to support efficacy in status epilepticus, at least in adults. The dose of fosphenytoin is 20 per kilo. It can be given IV, IO, or IM. When you give an IV, do not exceed 2 milligram per kilo per minute due to the risk of arrhythmias. EKG monitoring is required. Levetiracetam, 60 milligram per kilo up to 4.5 grams. It can be given IV or IO, is less sedative. Phenobarb, 20 per kilo to the max of 1 gram. It can be given IV or IO. As I told you, it will cause respiratory depression and hypotension, especially when we give as a second line medication because we already give benzodiazepam as a first line. Valproate, 40 milligram per kilo up to 3 milligram or 3000 milligram. It can be given IV or IO. It's also less sedating. Some more side effects. Fosphenytoin, it can cause significant hypotension, bradycardia, heart block, so you don't avoid in those circumstances, and overdose of recreational drugs or antidepressants. Valproate is good in patients already taking valproate, suspect of poor adherence, generalized epilepsy, comorbid migraine or mood disorder, and if alternatives are contraindicated, then use valproate. You should not use on women of childbearing age because it has a teratogenic potential, and also you should not use in pre-existing liver disease or pancreatitis, a known metabolic disorder predisposing to hepatotoxicity, and caution in acute stroke and brain injury because it can cause thrombocytopenia. When you use Keppra, use the dose 60 milligram per kilo to the max of 4.5 grams. It is preferable in patients already taking Keppra but poor adherence, and it has minimal drug interactions or when the alternatives are contraindicated or previously ineffective. As I told you, this is a go-to in the United States. May not be the best choice when there is acute or prior brain injury or known mood or behavioral disorder, and reduce the dose in patients with renal impairment. I'd like to discuss three trials that compare the different second-line anticonvulsants to find out which one is better, head to head. The first one, called Concept Trial, which was done in Australia and New Zealand. The children between 3 months to 16 years were studied. They studied the efficacy of 20 milligram per kilogram phenytoin and 40 milligram per kilo of levetiracetam. They did a subgroup analysis by onset, by presentation, by first-line anticonvulsants. They found no difference between phenytoin group and Keppra group. Regarding secondary outcomes like ICU admission, the length of hospital admission, and the median time for clinical seizure control, again, there is no difference between phenytoin group and levetiracetam group. They also followed up 1 month after discharge and 2 months after randomization. They found no difference between these two groups. So their conclusion is levetiracetam is not superior to phenytoin for second-line management of peds convulsive status epilepticus. This is concept trial from Australia and New Zealand. Eclipse trial. This is again to compare between levetiracetam versus phenytoin, but it was done in United Kingdom in 30 emergency departments. They also found there is no difference between these two groups. And also, trial adherence is similar in both the groups. Adverse events are not very different between these two groups. So their interpretation is, although levetiracetam was not significantly superior to phenytoin, the results, together with previously reported safety profiles and comparative ease of administration of levetiracetam, suggest it could be an appropriate alternative to phenytoin as the first choice second-line anticonvulsants in the treatment of pediatric convulsive status epilepticus because of the ease of use, availability, and safety profiles. So we prefer Keppra over phosphenytoin. That is Eclipse trial result. The third trial was done in the United States. There were 58 hospital emergency departments done this study. The inclusion, children aged 2 years and older. They compared these two drugs. They grouped the results into three: one children, adults, and older adults. As you can see, there is no significant difference between these three second-line anticonvulsants in children and also in the same in adults. But in older adults, the valproate works much better than other two. This picture shows the same thing. It is valproate does much better than other two, I would say, except 0 to 5 years, where phosphenytoin and Keppra are neck to neck. The interpretation of ESET trial, children, adults, and older adults with established status epilepticus respond similarly to levetiracetam, phosphenytoin, and valproate, with treatment success in approximately half of the patients. Any of these three drugs can be considered as a potential first choice second-line drug, benzodiazepine refractory status epilepticus. So the American trial says you can use any of these drugs, but the customary practice in the United States is Keppra. If seizure persists, you have given benzos, given second line anticonvulsants, then you need to consider continuous IV infusion of midas, pentobarb, or ketamine. You need to obtain PEDS neuro consult. EEG monitoring is must. There is no consensus in which third line infusion should be used at this point. Midas and pentobarb require secure airway, especially after prolonged seizures. Receive 2 doses of benzos. Invariably, they will have unstable airway. Securing airway is the best way to move forward. Number 2, both these medications can induce significant hypotension. Ketamine has less effect on BP and does not require intubation. Propofol infusion rarely used in pediatric patients due to the risk of propofol infusion syndrome. Additional treatments like ketogenic diet, corticosteroids, IV immunoglobulin, and vagus nerve stimulation should be considered when they continue to seize after 2 doses of benzos and other second line anticonvulsants. Some of the considerations when you're choosing the IV infusions. Midas, favorable hemodynamic profile. The bad thing is, if tachyphylaxis happens after 24 to 48 hours, it will become ineffective. It may deposit into adipose and cause prolonged sedation. Propofol, rapid clearance, that's a good effect. But it may cause dose-dependent hypotension, myocardial depression. Propofol infusion syndrome with extended use and is often observed in children. So it's often not used for this purpose. Ketamine, it is unique mechanism of NMDA blockade compared with other anesthetic options. It has a favorable hemodynamic profile. The association of ketamine with intracranial hypertension is not a concern with the contemporary work. So previously we used to avoid ketamine in patients with any kind of intracranial pathology. That's not the case now. It's unclear in half-life in high dose and prolonged infusions. Less studies are available with ketamine. Pentobarb is reserved for cases when all options fail, then pentobarb. The bad effect is it has a prolonged half-life in adults as well as in children. It causes cardiac depression. Invariably, these children will end up having vasopressors and causes bone marrow suppression. So you need to monitor for sepsis and causes ileus, kind of hard to do enteral feeding when you are doing pentobarb coma. So when you are dealing with refractory and super refractory status epilepticus, EEG monitoring is a must for seizure detection, and also it will guide anti-seizure drug titration. Adjunctive treatments like immunosuppressant ketogenic diet can be started when refractory becomes super refractory or even in between. One should consider autoimmune pathology, paraneoplastic panels, and imaging for tumors in adults. And also neuroimaging to look for the focus so that surgically you can remove the focus, thus we can control the seizure. This picture I throw in to show how the seizure evolves. A doesn't have any seizure activity. In B, you can see the seizure activity happens. And C, you can have the predominant effect on the red spikes that is coming from right hemisphere. Then D, you can see it kind of resolves. What is the outcome after status epilepticus? 2.7 to 5.2% of patients with status epilepticus die during the hospitalization. The long-term mortality after hospitalization can increase from 3.8 all the way up to 17%. The outcome depends on the duration of seizure and the underlying etiology. So stopping the seizure as soon as it presents is the best way to not only control the status epilepticus and also improve the mortality and morbidity. Some of the causes of status epilepticus have high mortality and high morbidity rates independent of the seizure, such as near drowning, sepsis, hemorrhagic shock, aspiration, and prolonged mechanical ventilation have high mortality and morbidity. Refractory status epilepticus can increase mortality up to 32%. Neurologic sequelae such as motor deficit, behavior and development problems, and new onset epilepsy can happen after status epilepticus. Once a status epilepticus happens, the recurrent seizure incidence ranges from 16% to 50%. They can have focal deficit, behavioral disorders, and cognitive disorders. One third of the patients will develop cognitive and behavior problems after status epilepticus. Younger the age of onset and the longer the duration of status epilepticus, they are the strongest predictors of worse neurocognitive outcomes. Close monitoring of the patient development, behavior, and cognition by both neurologist and the pediatrician after status epilepticus is essential. So take home points. Status epilepticus is a neurologic emergency. Timely intervention prevents seizure becoming status epilepticus. Always check glucose, calcium, and sodium. These are all remediable causes of status epilepticus immediately. And do not forget the diagnosis of meningitis and do not delay the antibiotics. Control the seizure within 30 to 60 minutes. Get the neurologic consult, get the neuroimaging done, and continuous electroencephalogram for status epilepticus is a must to identify the seizure and also to monitor the effect of anti-seizure medications. Thank you so much.